Hello, and welcome to this breastfeeding community and to the Miranda method, where we provide real help for real moms. I'm Miranda Johnson-Haddad, an international board-certified lactation consultant, and today I'd like to tell you about a recent lactation consultation that I did. The pediatrician had referred this mother and baby nursing couple to me because the parents had received many conflicting opinions from several people in many different fields about their newborn's possible tongue tie. 2 hospital lactation consultants, several hospital RNs, and 2 ENT, or ear, nose, and throat doctors, had diagnosed the baby as having a submuscular posterior tongue tie. Several pediatricians who looked at the baby, however, were skeptical. A 3rd ENT doctor said the baby's tongue was fine, but that he had an upper lip tie that needed to be released immediately, which the doctor proceeded to do, upon receiving the parents' approval, by clipping it. By the time the parents called me, their baby was 2 weeks old, and they had no idea what to think. All this poor mom knew was that breastfeeding was so painful that she wasn't sure she could continue, despite being strongly committed to breastfeeding. Now, here's the thing about tongue ties. Few topics are as controversial among breastfeeding professionals as this one. Typically, the controversy centers around how aggressively to treat a supposed tongue tie, and whether or not treating it will improve breastfeeding outcomes. You may have heard the terms tongue tie, frenulum, and frenotomy, but not be sure exactly what they mean. And the term submuscular posterior tongue tie may be completely new to you. Or you may have received a diagnosis of tongue tie for your baby, or even a recommendation that you treat it surgically. You may, like the mom I worked with, have received conflicting diagnoses and advice. So let's try to demystify this subject a bit. Human beings all possess a thin membrane called a frenulum located under their tongue that connects the tongue to the floor of the mouth. Ideally, the frenulum is positioned way back under the tongue, but in some babies, the frenulum is so far forward that it is actually attached to the front tip of the tongue. When this happens, we say that the baby has an anterior or front tongue tie. Usually, the frenulum will stretch as the child grows, so only in a small percentage of people will a tight frenulum affect speech. But a tight or short frenulum can definitely have a negative impact on breastfeeding, because if the baby cannot extend her tongue past her lower gum line, she won't be able to cup her tongue under mom's nipple and effectively milk the breast. Instead, she may only be able to flick her tongue at the very center of her mother's nipple. And it doesn't take long for breastfeeding to become extremely painful for mom and unproductive for baby, who isn't transferring milk and may not gain enough weight. With this type of anterior tongue tie, there's usually a pretty easy fix. A physician can perform a frenotomy, in which, using a special tool to lift the baby's tongue, the doctor can then snip the frenulum with a pair of small, sterile surgical scissors. Although parents tend to wince when the procedure is first described to them, there's really nothing to it. The frenulum is a membrane that contains few or no nerve endings, and it often doesn't even bleed. The baby may be outraged by the procedure, but she's unlikely to experience more than a moment or 2 of discomfort, if that. Mom can usually breastfeed the baby immediately after the frenotomy, and many times I've seen a look of wonder and relief pass over the mother's face as she exclaims, "Wow, that feels so much better." Happy ending, right? But a submuscular posterior tongue tie is a completely different matter, and releasing such a tongue tie is a much more invasive procedure. The various types of physicians who may perform this procedure, including pediatricians, ENT doctors, and some pediatric dentists, may use different tools to achieve the release, but it's always a much more complex process than a simple frenotomy is. Many moms who elect to go this route also experience considerable relief. But with a procedure this invasive, I start to worry about the impact on the baby and on breastfeeding. By now, you may be wondering about the family that I described at the beginning of this talk and what they decided to do. Well, as I told the mother when she first called me, I firmly believe that the only way to determine whether a baby's tongue is getting in the way of comfortable and effective breastfeeding is to observe what that baby is actually doing when on the breast. I've seen babies with visibly tight tongue ties do just fine on the breast, and mom is comfortable. But I've also seen babies with pretty minimal tongue ties who aren't able to achieve an effective latch or transfer milk, and the poor mom is curling her toes with pain every time the baby nurses. With this particular mother-baby dyad, the baby gaped his mouth open beautifully wide, achieved a textbook latch, and flanged his bottom lip out perfectly. A baby who is tongue-tied often won't be able to do these things. Given his ability to do all this, I was not at all convinced that his supposed posterior tongue tie was hampering him at the breast. What was significant, however, was the fact that once he was on the breast, he seemed terribly confused, and with good reason, as I soon learned. In the first few days of life, this little guy had had the following things in his mouth: the breast with a nipple shield, which had been wrongly given to this mom while in the hospital before her milk even came in, finger feeding with a syringe, an SNS, or supplemental nursing system, in which a thin tube is taped to the mother's nipple, and at least 3 different types of bottle, to say nothing of having had his upper lip frenulum clipped. And every single one of these items requires a baby to suck differently. No wonder he was confused. I worked with the mother and baby at the breast and encouraged her to try to minimize what went into his mouth. Ideally just the breast, without the shield if possible, and only one type of slow flow bottle when needed. It took a lot of dedication and practice, but eventually the baby began to get the hang of nursing. The parents were deeply relieved that he didn't seem to require an invasive procedure to release his tongue. So, what's the moral of this story? Simply put, it's that every baby is different. If you've been given a diagnosis of tongue tie for your baby, you need to see an experienced lactation professional who can observe the baby at the breast and do an oral assessment of your baby to the extent that she feels it's within her scope of practice. But if you received a diagnosis of a submuscular posterior tongue tie for baby, it's especially important to get a second opinion and a third, or however many you need to feel comfortable before agreeing to an invasive procedure to release the baby's tongue. Sometimes there is another explanation for why a baby is struggling at the breast, as was the case with the baby I've described here. And sometimes a simple solution, such as lots of practice at the breast, really is all that's needed. Parenting is complicated enough without elaborate diagnoses that turn a fairly straightforward situation into a needlessly complex one. I'm Miranda Johnson-Haddad of the Miranda Method. I hope you've enjoyed this talk, and I'll be with you next time.